Welcome to part 2 of Anatomy of an Anesthesia Machine. I'm Dr. J.T. Murphy of the Department of Anesthesiology at the University of Kentucky, and I have no financial disclosures to make. In this presentation, I will not be discussing the physics of the anesthesia machine, which will be presented by Dr. Hessel next week, nor will I discuss in detail the physical properties of gases, vapors, liquids, of vaporizers or ventilators. I will touch upon flow meters to a certain extent. The learning objectives for this podcast are shown in this slide, and I would expect that you would be able to state the volume and pressure of oxygen and nitrous oxide cylinders on our anesthesia workstations, and to explain how a circle anesthesia system works, to explain how carbon dioxide is eliminated in a circle system, to describe how to use a non-rebreathing system, and also to discuss and outline the benefits and risks of gas scavenging systems on anesthesia workstations. Primary references for this podcast were taken from Chapter 25 of Miller's 7th edition and from Chapter 29 of Miller's 8th edition. If you notice, Dr. Jeff Andrews is co-author in both these chapters, and it is interesting to note that the number of key points increased from 14 to 24 between these two editions. A secondary reference is Anesthesia Equipment Principles and Applications, 2nd edition. This book is available electronically, and you can print the chapter for your own references, should you desire. So first, let's talk about the circle. This is the main anesthesia circuit in use at the University of Kentucky. This breathing system, which can be used in a semi-closed or closed way, is more complex than the Mapleson series of breathing systems. The 7 components of a breathing system are enumerated on this slide. Fresh gas inflow, 2 valves, 2 tubes, a Y-piece connector, a pop-off valve or an APL valve, a reservoir bag, and a canister containing an absorbent for carbon dioxide. There are numerous variations of component placement within the circle. However, to prevent rebreathing of carbon dioxide, the following 3 rules must be followed. Number 1, a unidirectional valve must be located between the patient and the reservoir bag on both the inspiratory and expiratory limb of the circuit. Number 2, the fresh gas inflow cannot enter the circuit between the expiratory valve and the patient. Here is the fresh gas flow entering in quadrant A, which satisfies this rule. Number 3, the overflow or pop-off valve cannot be located between the patient and the inspiratory valve. This is the patient, this is the expiratory limb, the expiratory valve is on the expiratory limb. It's pretty straightforward. Now, the circle breathing system is a complex system, at least compared to open drop ether, etc., etc. There are many connections and sources of leaks. There have been life-threatening complications with valve malfunctions. In years gone by, valves would become stuck in the open or closed position, and the system would fail. It's for that reason that the valves are designed to be visible, so that the user can visualize the valve opening and closing. Notwithstanding its complexity and disadvantages, it does have advantages. It does facilitate low flow and closed circuit anesthesia. It may maintain humidity within the patient without the addition of humidifiers, etc. This, of course, is only true if you are using a closed circuit and the amount of oxygen which you're adding to the patient is very low, equal to metabolic oxygen. The circle breathing system allows the easy practice of closed circuit anesthesia, which is a topic unto itself. Here are some books which can be referred to for closed circuit low flow anesthesia. The one on the left was published in the 1980s and was one that I used when I was a resident. Now, this is a direct cut and paste from Miller's 8th edition, and it is mainly a caveat emptor for the end user, and all anesthesia end users should be aware of the fact that that the ingenuity of some individuals in outwitting foolproof systems can lead to dangerous anesthesia machine modifications. Therefore, everyone who uses a particular anesthesia machine should know exactly how it's used and what its safety features are. I don't know if this means that we should not use double length extensions on our adjustable length circuits or not. The anesthesia workstation engineers have likely designed the breathing circuit to function with tubing of a certain length and compliance. Automated checkout and compliance compensation may be performed by the machine, but not if the circuit is modified after the checkout has been performed. Anecdotally, we have seen several underventilation situations in pediatric patients, sometimes with older anesthesia machines which do not have compliance compensation, sometimes after modification of the circuit. Nonetheless, it is important that the operator uses the workstation, and the technicians who prepare the machine for use be knowledgeable about its proper setup. Carbon dioxide has to be scrubbed from the airway gases when closed and semi-closed systems are used. A circle system can be used without soda lime, but the fresh gas flow and minute ventilation must be equivalent to that for a Mapleson circuit. For example, a Bain circuit or modified Mapleson D. If you know the fresh gas flow and minute ventilation that is required for a Mapleson D, you can use the same settings for a circle system that does not have the absorbent in the canister. It will not eliminate rebreathing, but it will control the patient's carbon dioxide. The carbon dioxide canister itself can be a source of leak or of obstruction within the system. All sorts of case reports of obstruction or malfunction or channeling have been made and are well documented in the literature. Carbon dioxide is usually removed physically by combining with the sodium hydroxide, etc., in the soda lime. And an indicator, usually ethyl violet, is used to indicate that the soda lime is being used up. Now, When you read about soda lime, you see the term that the size of the granules should be between 4 and 8 mesh. What does this actually mean? Well, it means that the granules are supposed to fit uh, uh, through a mesh that is uh, either 4 or 8 square. It just means that it shouldn't be a powder and it shouldn't be rocks. Carbon dioxide reacts with the absorbent in a series of chemical reactions. The end products are heat and water. There are carbon dioxide complications, such that there are absorbent and anesthetic interactions. Some of them are old, with trichloroethylene, where toxic compounds were created. Sevoflurane reacts to form compound A. All agents have the potential to produce carbon monoxide. Dry absorbent increases the risk of carbon monoxide production. The order of carbon dioxide risk appears to be desflurane, enflurane, isoflurane, halothane. You may or may not have seen videos of fires occurring on anesthesia machines, which are related to high canister temperatures. They are relatively rare. We have had nothing like this at University of Kentucky, to my knowledge. So to summarize, the guidance for the prevention of adverse interactions between volatile agents and absorbents, I have cut and pasted this small paragraph from Miller's 8th edition, and as you can see, it's recommended that when the machine is not in use, all gas flow be turned off. Second, that absorbent be changed regularly. Third, that the absorbent be changed whenever the color change indicates exhaustion, although one must be aware of the fact that the color can become faded and you may miss the fact that it has become exhausted. If there is a 2-canister system, change all the absorbent. At any time when there's uncertainty about the state of hydration of the absorbent, go ahead and change it. And finally, if using compact canisters, they should be changed more frequently. Well, that only is logical. So, breathing circuits. Well, this chapter in our secondary reference is an excellent resource for the circle system and for other systems. The other systems I'm going to briefly review are classified as largely as the Mapleson classification of breathing systems, and this figure shows the 5 or 6 or 7 variants of where fresh gas flow and the pop-off valve, etc., may be located in a semi-closed or rebreathing system. Rather than memorize which one is best for spontaneous breathing, although it is the Mapleson A and I've never used one, and which one is best for controlled ventilation, which I think is the Mapleson D or the Bain circuit, I suggest that you concentrate on the fact that hyperventilation cannot reduce the arterial carbon dioxide if the fresh gas flow is kept between 1 and 2 times a minute ventilation. A circle system with an empty absorbent canister will function the same way. An interesting circuit available on the market is the Universal F, which was probably invented after the Mapleson classification And this is a coaxial circle, and in addition to being connected to a standard circle system, it can be used for transport. Now, I want to spend a few minutes reviewing the Bain system. Bain circuit, Bain system is a modified Mapleson-D that does function most efficiently with controlled ventilation. With a fresh gas flow of 70 mils per kilo, carbon dioxide will be controlled adequately if the minute ventilation is approximately 2.5 times the fresh gas flow. So for a 70 kilo person, this means a fresh gas flow of 5 liters per minute, for example, 3 liters of nitrous oxide and 2 liters of oxygen, and a tidal volume of about 700 mils per breath 15 times per minute, or 1,000 mils per breath 10 times per minute, or something like that. For spontaneous ventilation, the fresh gas flow should be 100 to 150 mils per kilo. Now, theoretically, perhaps you may use a Bain circuit in someday with a total intravenous anesthesia. This Bain circuit, this lightweight plastic circuit, was designed to be attached to a mount as pictured on this slide and on the next slide, which shows that the fresh gas flow came from the common gas outlet of the anesthesia machine, and that is the center smaller tubing shown in green in this cartoon. There is an expiratory channel in the circuit, and expired gas could be collected and scavenged. The anesthesia provider could be the ventilator squeezing the bag, or the circuit could be connected to an anesthesia ventilator. It was a revolutionary advance in anesthesia care at the time because of the fact of it replacing heavy rubber tubes which absorbed agent and which were hard to clean and to sterilize. And as you probably are aware, the Bain circuit was invented by 2 Canadians. I do encourage you to read the original paper. It's only 10 pages in length with photos, and this special article from 2014. There's no doubt that we do not ventilate patients the same in 2015 as we did in 1972. The development of lightweight plastic circle systems may have well supplanted the benefit of the Bain circuit. You may or may not have noticed that the Bain mount can be placed on a pole, not attached to the anesthesia workstation, and in fact be used without an anesthesia workstation, such as in our safari cases. Now, Bain circuits are not available any longer at the University of Kentucky, presumably due to a lack of demand. Yet I believe that as consultant anesthesiologists, you should be aware of the Bain system and know how to use it. You should be aware that if the inner oxygen supply tube is disconnected, the system will malfunction. The special article probably accurately summarizes the international use. Rarely in North America. In fact, as I just mentioned, we cannot buy the Bain system any longer. Now, I want to make you aware of the fact that material management selected some other kind of system as its replacement without any discussion with the clinical users. And while it was possible to attach this system to our Bain mounts, it was not a Bain circuit and did not function like a Bain circuit, or at least there was no guarantee that it would. So, in conclusion, it appears as if the modified Mapleson-D Bain circuit is in use in the United Kingdom, perhaps mainly in anesthesia induction rooms, and it does appear to be sold in Asia. Now, let's move on to oxygen supply. There's an auxiliary cylinder on the anesthesia machine, and there's pipeline. Oxygen may be stored in liquid form or in bulk large cylinders on the facility. This table was cut and pasted from Dorsch and Dorsch 4th edition 1999 and summarizes, I think, in a pretty clear way the cylinder sizes and their pressures and volumes, and the usual cylinder on the back of the anesthesia machine is an E cylinder, this one here. And as you can clearly see, it has a volume of 660 liters for oxygen and 1,590 liters for nitrous oxide. This chapter in anesthesia equipment is an excellent reference source, and this slide serves to show how the pressure in a oxygen tank is proportional to the volume in the tank, and how this is not the case with nitrous oxide because there's a liquid in the nitrous oxide cylinder. This is Boyle's law. Nitrous oxide follows Boyle's law, but only after all the liquid has evaporated. Now moving on to safety features. Medical gas cylinders have a number of safety features. First, the rupture disc. It's also known as a frangible disc and is a non-reclosing device that ruptures when a predetermined pressure is reached. Then the fusible plug. A fusible plug is a thermally operated non-reclosing pressure relief device. The yield temperature is the temperature at which the fusible material becomes sufficiently soft to extrude from its holder so that cylinder contents are discharged. At one time it was mandatory knowledge for anesthesia residents and to learn the composition of the fusible plug, but I don't think that that's particularly useful. The next slide refers to the pressure relief valve, which is a spring-loaded device designed to reclose and prevent discharge of cylinder contents after normal pressures have been restored. Pressure relief valves are more prone to leak, of course, than rupture discs or fusible plugs. And finally, the pin index system is a safety feature which is found on cylinder sizes A through E. There are 7 pins positioned on the circumference of a circle so that only the correct cylinder can be mounted on the yoke, as long as the pins are functional. So this pin index system is a safety feature that you should be aware of. The radius of 9/16 of an inch is not important. So these figures show the cross section of typical cylinder valves. The one on the left, part A, is typical of smaller cylinders, while the figure B is typical of large cylinders, such as an H cylinder. You should be aware of the fact that larger cylinders have unique outlet port diameters and threading for safety, another safety feature. You may or may not be surprised to know that the color marking of compressed gas containers is not consistent internationally. The Canadian color for oxygen is white. The US color is green. Notwithstanding that, when I was in my residency, many people referred to oxygen as the green gas. I think we received cylinders that were both green, either green or white. So as you can see, there's some variability, and other countries could possibly have a different color coding system. So all anesthesia workstations should have at least one oxygen cylinder. Pipeline oxygen comes from liquid oxygen storage or bulk oxygen cylinders. This figure shows a typical H-size supply system, as would be found in a small hospital or a freestanding facility. And this is kind of a simplified version of the previous slide, and there's a changeover valve which automatically switches to the secondary supply once the primary supply has been exhausted. Now this is a system which uses liquid oxygen. And finally, this is a system which would be found in a large hospital. 1 cubic foot of liquid oxygen at a minus 183 C expands to 860 cubic feet at 21 degrees C. Liquid oxygen supply systems are strictly regulated and have alarm systems. In addition, there should be a system whereby mobile oxygen supply can be connected in the case of failure or extended repair. This is found at number 22 on this schematic. So this whole complicated liquid oxygen supply system can be bypassed at this T point here. And as mentioned, the oxygen supply and other gases are monitored, and alarms can be activated by changes in pressure and notifying the users in their location. Moving along, a regulator is a pressure reducing valve. The oxygen cylinder pressure regulator reduces the pressure from 2,200 pounds per square inch to approximately 45 pounds per square inch. The nitrous oxide pressure regulator reduces the pressure from 745 to 45. If you can read the legend on this figure, you'll see that there is some discussion of the differences between anesthesia systems, one brand and another. Pressure regulators are positioned between the cylinders and the intermediate pressure system, and also between the intermediate pressure systems and the flow meters. And of course, like any piece of equipment, can either function or malfunction. This is a zoomed in part of the previous slide, and this schematic shows the working parts of a direct acting oxygen pressure regulator. And as you can see, there are springs and diaphragms and such that the design of the regulator is to keep the low pressure fairly constant despite changes in the higher inlet pressure. This is a familiar two-gas anesthesia machine schematic, and I've outlined the location of the pressure regulator for nitrous oxide and the second stage oxygen pressure regulator. And as I mentioned, all these pipelines have pressure gauges on them, and this can be monitored by either by the end user or by the machine. Now, anesthesia workstations have E-cylinders, as I mentioned before, with a volume of 660 liters, and the cylinders attach to a yoke on the machine and hangers with a pin index system. The check valve allows removal of the cylinder without leaking. The cylinder should be turned off except when in use. Anesthesia workstations also have a pipeline oxygen supply. These attach using the diameter index safety system. And this is also designed to minimize erroneous gas delivery. There's a check valve downstream to prevent incorrect flow. A full E-cylinder of oxygen will last about 10 hours at 1 liter per minute. An E-cylinder with only 500 pounds per square inch pressure is about 1/4 full and will last for about 2 hours at 1 liter per minute, but only for 12 minutes at 10 liters per minute. Anesthesia workstations, if they are equipped with may or may not have an E-cylinder for nitrous oxide, and I encourage you to examine the Apollo anesthesia workstations at the University of Kentucky and see which ones have a nitrous oxide yoke and which ones do not. Nitrous oxide is also supplied by pipeline. These attach using the diameter index safety system. If there is no pipeline and you are using a nitrous oxide E-cylinder, there's about 250 liters in the cylinder at 745 pounds per square inch when all liquid nitrous oxide is evaporated. Therefore, when you notice that the nitrous oxide cylinder is beginning to drop in pressure and all the liquid has evaporated, you have about an hour or so to replace the cylinder. Theoretically, it does depend on the flow, of course. The ratio of volume of nitrous oxide to oxygen in the E-cylinders is about 2 to 1. Therefore, at a fresh gas flow of 3 liters per minute and a ratio of 2 to 1, both E-cylinders on the anesthesia workstation will need replacement after approximately 8 hours of use. Another safety feature of anesthesia machines involves the gas keying style, and gas outlets have been designed and produced by a variety of companies, and these photographs show you the Schrader, the Puritan Bennett, the Ohio, the Chematron, and finally the diameter index safety system. This is distinct from the quick connectors shown in the previous slides. This system is composed of a body, a nipple, and nut connection, which is specific for the gas. These pictures here show examples of hoses with a diameter index safety system and their connections on anesthesia machines. Scavenger. At one time, anesthesia machines were not scavenged. However, things have changed, and all anesthesia machines have scavenging. Of course, being a mechanical device, it is designed to be used in a certain way, and it needs to be checked, and there's risks and benefits to it. I'm not going to discuss the risks of chronic exposure to atmospheric pollutants. However, it's pretty obvious that no one wants to be exposed to anesthetic agents and or nitrous oxide on a chronic basis. So the main advantage of a scavenger is it reduces atmospheric pollution. Of course, it discharges it into the atmosphere. Atmospheric pollution in the operating room, but it discharges the agents into the world. The disadvantage is that it adds complexity to the system. Scavengers are composed of a gas collecting assembly, a transfer means, a scavenging interface, a gas disposal assembly tubing, and gas disposal assembly. This is a slide cut and pasted from Miller's 7th edition, and it is pretty straightforward. Scavengers can be either passive or active. The one on the left shows a closed scavenging system, which can be either active or passive. Depending on it's possible that if the fresh gas flow is very high, that there's a spill into the room. The figures on the right show open scavenging systems, which require active disposal, in other words, vacuum. Scavengers have hazards. Excessive positive pressure or negative pressure can be exerted on the patient. Large volumes of oxygen can be dumped into closed spaces, increasing the potential for fire. This last statement relates to the oxygen from anesthesia machines ending up in an enclosed space in a hospital rather than being vented to the atmosphere through a pipe going through the roof, for example. There are novel scavengers. Perhaps sometime there will be a charcoal filter to absorb volatile agents. This is a handmade charcoal filter which was published created in Korea, and which could be used to accelerate emergence from anesthesia. More practically, there are charcoal filters to absorb volatile agents and to prepare anesthesia machines for MH-susceptible patients. The Vapor Clean filter by Dynesthetics is recommended by M-House. I show you a image from their website. These filters apparently come in pairs. These ones are now orange. It appears that the filters that we have at the University of Kentucky are still gray. I think there's been a color modification. Now, this concludes my presentation, part 2. There's a lot to know about anesthesia machines and the function of every component. And really, I think you have to be inquisitive and critical about the use of the machines, and not only accept the pass or fail of the machine through an automated check. You should try to learn the weak points of the anesthesia machine. Every machine is imperfect. For example, on the Apollo, it's quite possible that the sample gas tubing gets caught underneath the APL valve. It's possible that the disposable carbon dioxide system, for example on Apollo, the click system, which is quite neat and tidy and dust-free, it is possible that malfunctions. You've not seen any of these click systems at the University of Kentucky. We did trial them, and they're not without their risk. You can seriously underventilate someone if the canister has become detached. Now, of course, you will pick up a very rapidly rising inspiratory CO2. So there are checks and balances. There are safety features for all machines, but really they're only as good as the end user's knowledge of the machine. So in conclusion, I suggest that you review the references in Miller and perhaps in the Aaronworth textbook in order to become more well-rounded and knowledgeable about anesthesia machines, circuits, and the safety features of all these machines. I thank you for your attention, and the best of luck on the quiz. The questions that you'll find on the wiki, which address the two podcasts on this topic.